unnecessary use of antibiotics, such as for minor infections that can resolve on their own, as well as changing medical practice to prevent hospital infections, can have a major impact by keeping more non-resistant bacteria alive as competition for resistant strains. In the war against superbacteria, de-escalation may sometimes work better than an evolutionary arms race.
Okay, thank you very much. Thank you very much for joining in. So now we're about to start it because the time is ticking away and people will be joining as the meeting progresses. So, so what do you need to learn about this antimicrobial resistance thing? Antibiotic resistance can affect people at any stage of life. Infections caused by resistant germs are difficult, sometimes impossible to treat. And these infections, they require extended hospital stays, additional follow-up doctors' visits, and the use of treatments that may be costly and potential toxic. So everyone is involved in this antimicrobial thing, whether a doctor, whether an engineer, whether a nurse, whether a teacher, everyone is involved. Because one way or the other, we're gonna be using the antibiotics, and the medical professions are going to be giving patients the antibiotics as well. So we need to understand how to use these medicines in low and income countries and even in those that have better economy and all. So without wasting much time, I would like to introduce our first speaker for the opening remarks, Mr. Ngoni Muzondo. So before that, maybe I've introduced myself before most participants had joined. My name is Ngoni Muzondo. I'm the current chairperson of the Education Office at Zimbabwe Pharmacy Students Association. So together with my office, we planned this meeting, and it is in conjunction with Students Against Superbugs. And I'm sure you learn a lot from the head of the club, and you share a lot pertaining to the club and what we do as well. So let me introduce our first speaker, Mr. Tapiwanashe. So he's the head of Drug Research, Discovery and Innovations Program at Students Against Superbugs Africa. So he's learning at Jomo Kenyatta University of Agriculture and Technology in Kenya. So, Mr. Jimmy, you can take up the stand and give us some opening remarks. Thank you very much.
Okay, thank you so much. Thank you, Ngoni. Thank you, everyone in the group. Okay, my name is Jimmy Ngaiwatei. I'm a student at Jomo Kenyatta University of Agriculture and Technology, Kenya. Okay, I'm also the head of drug research and development at CAS Africa, Students Against Superbugs Africa. Thank you so much for this talk. CAS Students Against Superbugs Africa in conjunction with the Zimbabwe Pharmacy Students Associations. First, before I proceed, let me know if I'm audible enough.
Yeah, you're audible.
Okay. Okay, thank you so much. Maybe, yeah, without taking not much time, first, let me apologize because I'm not in a position to share my video, but let me just talk a brief about Students Against Superbugs Africa, because that's where I am. Okay. Students Against Superbugs Africa is a registered student-driven initiative that does antimicrobial resistance stewardship activities for mitigation of antimicrobial resistance in Africa communities under the One Health approach. We do this with a keen focus on rural and urban former settlements for the purposes of mitigation of antimicrobial resistance. We do this by mainly, our main mandate is to empower the young people to be the lead advocates against antimicrobial resistance. We know the young people, they are the next leaders, the future generation of leaders. So it is good to prepare them early enough to become quality leaders in the future. Under the CAS Africa, we also have another program there for drug research, discovery and innovation, whereby it is a platform whereby we are nurturing the young researchers to produce excellent researchers and producers. So the major challenge that is facing Africa currently is a lot of research. There is inadequate research as far as the health sector is concerned. Actually, I believe by the end of, in the next few years, CS Africa is going to produce quality researchers. That's our mandate. We want to produce quality researchers out of CAS. Maybe, yeah, alongside the research, we also have the stewardship activities and the interventions really for the purposes of creating awareness against antimicrobial resistance. And we do this by use of interdisciplinary approaches. We're not only involving the medical students, we also involve other students across all the learning disciplines, including the medical, biological, and social sciences, because everyone can play a role in the mitigation of antimicrobial resistance. And maybe to state some definition, because I do understand that you have some fellows here, maybe who may not understand the meaning of antimicrobials. I do understand there are those students in the area of medicine or biological sciences who will understand the term, but maybe I just like to let them know the antimicrobials, these are the drugs that are normally used to suppress infections, any infection, be it bacterial, viral, fungal, yeah, and etc. Those are the antimicrobials. These are simply drugs that are used to treat infections. Maybe to go on, the mission of CAS Africa is to mitigate the threat of antimicrobial resistance and improve the overall quality of life in African communities by empowering young people to be focal advocates in AMR through training and instilling in them the virtues of social responsibility by by engaging in effective education, infection prevention and control, research and innovation programs using the One Health approach. Our vision is to be a led youth-driven organization curtailing the threat of AMR in Africa and contribute actively to global solutions. Okay, maybe, yeah, I just would like to touch some points on the antimicrobial stewardship. Antimicrobial stewardship, simply, these are just coordinated activities or programs that promote the appropriate use of antimicrobial agents to prevent AMR, improve patients' outcomes, and reduce the spread of antimicrobial resistance. To classify, maybe you can say that we have the broad antimicrobial stewardship programs, the pharmacy-driven antimicrobial stewardships programs, infection and syndrome in specific antimicrobial stewardship programs. Maybe I just like to highlight specifically some of these under the broad categories. You have the hospital-based antimicrobial resistance stewardship programs, the community-based MS, that is antimicrobial stewardship activities, and also we can do this by the setting up implementation of the national action plans towards mitigation of AMR. The community-based and the hospital-based majorly, they are meant to increase awareness and do the AMR surveillance. Maybe I can just say that some of the principles to ensure that we have the appropriate use of antibiotics, it is good that the principles that do govern this is that first, the antibiotics should only be prescribed only when needed. Secondly, the antibiotics are only meant for bacteria. Third, the appropriate use of antibiotics involve only those infections that have been diagnosed and confirmed to be specifically maybe bacterial infections, fungal infection, parasitic infections, for example. So diagnosis play a very critical role in prevention for antimicrobial resistance, because that's the only way that you realize that I'm treating a particular infection. Another point is that prescribing the right dose and duration of antibiotic treatment is so important in the prevention of antimicrobial resistance. Actually, it is one of the important points that should be noted by the medical practitioners. We have so many other points that, but it is just, I've just highlighted some of the important points that we should not when dealing with antimicrobial resistance. My friend Ngoni, I think without taking not much time, I'd like to stop there and invite our other speakers to proceed with our presentation. Thank you so much and have a wonderful evening. Over to you, Ngoni.
Ngoni, I think you are muted.
Thank you very much, Jimmy, for such a wonderful presentation on antimicrobial resistance and SAS Africa. So for those in Zimbabwe, we are having a club on SAS currently. So for more information, we'll create a group and then we share more on SAS. So I advise you guys to join the club, those who are interested in research and those who just want to learn. So thank you very much, Mr. Jamie. So I would like to introduce our next speaker, Mr. Dr. Jaguga. So Dr. Collings Jaguga is a public health and health systems pharmacist with 19 years of experience in health and pharmaceutical services in low resource settings. So he has held senior managerial and technical positions in the private and non-governmental sectors, supporting strengthening of health and pharmaceutical systems and services in sub-Saharan Africa. He has provided technical oversight in the implementation of health and pharmaceutical projects in Chad, Democratic Republic of Congo, Ethiopia, Kenya, Liberia, Malawi, Nigeria, Rwanda, Sierra Leone, Somalia, Somaliland, Tanzania, Uganda, and Zambia. So he's a pharmacist by profession, holding Bachelor of Pharmacy, graduate with a Master's of Business Administration in Healthcare Management, and a Master of Science in Global Supply Chain Management, MSG SCM. So in 2019, he was the recipient of $50,000 tuition scholarship awarded by the University of Southern California, Los Angeles, USA, to pursue the MSG SCM degree. So Mr. Collins, you can take up the stand. Is going to talk on antimicrobial resistance being the global silent tsunami. So Mr. Dr. Collins Jaguga, you can take up the stand. Thank you.
Good evening, listeners. Can you hear me? Can you hear me?
Sir. Yes,
great. Great. Thank you very much, Ngoni, for your kind words and kind introduction. I think without further ado, I'd like to go ahead with my presentation. Let me share my screen. Okay, is my screen visible?
Yes, it's visible.
Yes, yes, it's visible.
Great.
Yes.
Great, and good to know that that I'm also audible enough. Otherwise, greetings from Nairobi, Kenya. And Ngoni, once again, thank you very much for organizing this forum to discuss a very, very important topic, I must say. Really a global public health concern at the moment. So what we'll discuss in the next couple of minutes is what antimicrobial resistance is and why it is currently being known as the global silent tsunami. In some settings, tsunami has been replaced with pandemic, the global silent pandemic. I believe we are all aware of the ongoing COVID-19 pandemic that is loud. I don't think there's anyone on this planet who does not know what COVID-19 is. Well, I'll not be surprised if there's somebody somewhere in some part of this doesn't know what COVID-19 is, but there are quite a number of people, I can bet, who have no idea what antimicrobial resistance is, yet it is an ongoing tsunami. It is an ongoing pandemic that is killing, literature says about 700,000 people annually globally, and that if nothing is done about it, we risk losing up to 10 million people annually by the year 2050. It's unfortunate that people who have antimicrobial resistance do not have distinct features. HIV/AIDS, you can tell, right? Somebody who is emaciated, somebody who is wasted, you can tell. But AMR has no face, right? And unfortunately, even data on AMR is generally poor, and especially in low and middle income countries. So in the next couple of minutes, we will get to understand what AMR is. And thank you for our colleague who has just spoken a few minutes before me for setting a very, very good, preamble to the topic. You have discussed in summary what AMR is and even gone ahead to define what antimicrobial stewardship is. Thank you very much. So there is this quote by Dr. Margaret Chan, former Director General, WHO 2015. She said that antimicrobial resistance is a crisis that must be managed with the utmost urgency. She went ahead and said that we cannot allow hard-won gains for health to be eroded by the failure of our mainstay medicines. So it is a global crisis. It's a global pandemic. So by the end of this session, which will take about 20 minutes or so, we should be able to define or understand what antimicrobial resistance is, and we'll use the acronym AMR. We should be able to describe how the spread of AMR occurs, and just to understand what are some of the strategies to curb AMR in our local settings. It's one thing to know what it is, it's one thing to know what the burden is, it's another thing to know what can we do in our settings to prevent, to contain antimicrobial resistance, even as pharmacy students. And I believe we are not only pharmacy students. I believe we are students, doing various courses. AMR is not just a health concern. It is a global problem that should concern everyone, and we will see that in a short while. So in a nutshell, my presentation, there'll be a brief introduction, then we'll define what AMR is. We'll get to understand why it is a global concern, what accelerates the emergence and spread of AMR, and how we contribute to this spread. And then I thought it would be good for us just to understand this concept of the One Health approach to combating antimicrobial resistance, what we're calling a coordinated response. So, quick introduction, and I liked the student who went just before me, who attempted and then really gave a very good definition of what these antimicrobials are. So just trying to break down what antimicrobials are. Anti means against, micros little, bios life. So these are Greek words. Okay? So that's just a breakdown of the term antimicrobial. Antimicrobials include antibiotics and antibacterials, antivirals, antiparasitic agents, and antifungals. I believe most of you have come across these terms. Antibiotics generally act against bacteria, antivirals against viruses, antifungals against fungi, and antiprotozoals against protozoa. I think we need not go into into pharmacology. I believe you have been taught this. So in that, can I call it reddish or brownish table? There are examples there. For instance, antibiotics or antibacterials. These act against bacteria. For instance, drugs for bacterial pneumonia. Say amoxicillin or co-amoxiclav. For instance, antivirals. I believe you know some examples. Those that are used for herpes, those that are used for HIV, etc., etc. Drugs used against parasites, e.g. those used for malaria. I believe these are not new to artemisinin, combined therapy, and the likes. Then against fungi, e.g. drugs for yeast infections. Right, and I believe you're aware of many antifungal drugs that are available in the market, busulfulvin, sporanox, etc., etc. So that's just but a quick introduction. So having said that, there is a question here that all antibiotics are antimicrobials, but not all antimicrobials are antibiotics. Is this true or false? Quite often we use these two terms interchangeably, but there is a difference, and I think we've just seen that in the slide that came before this. So I would like to request us, hopefully we can be able to type something in the chat to respond to this question. So simply write true or false. Are they in agreement or in disagreement with this statement? As we go along, we may use them interchangeably for the sake of communicating our message, but strictly speaking, there is a difference. So please post your responses in the chat. Don't be afraid to write what you think the answer is. Okay, you can see people responding. I know if you're using your phone, it may be a bit challenging, but it is still possible for you to type your response. Okay. Good. So I will continue. So what is antimicrobial resistance? I've tried to really break it down, to use very simple language or simple English. So antimicrobial resistance occurs when microorganisms change and render the antimicrobials that were previously effective against them ineffective. Right? Microorganisms change. They either undergo mutation or there's some target modification or increased efflux of the antimicrobial, so that the antimicrobial is now ineffective against against it being the microorganism. So the microorganism has undergone some transformation so that antibiotics, the microbials that were previously effective against them are not. So these microorganisms that undergo certain changes that we talked about, and as a result of the changes that they undergo, antimicrobials are not now able to act, against them, are known as superbugs. I'm sure you've come across this term, superbugs, microorganisms that are resistant to most antimicrobials. Yeah, and the superbugs can spread both at the hospital level or the community level. So in simple terms, that's what the microbial resistance is. Mechanisms have undergone certain changes and microbials can no longer work against them. And in other words, they have developed resistance. And so they're known as superbugs. Right? So how does antimicrobial resistance emerge and spread? Yeah, and I like that this was alluded to by our colleague who set a very good preamble. So one, misuse and overuse of antimicrobials. Yeah, inappropriate prescribing of antimicrobials for simple viral infections. As it were, shortly after this presentation, and I think I mentioned to Ngoni, I will request to drop off from this call and rush Mesant Hospital, who I suspect has a viral infection. He's been having spiking fevers the last 48 hours. We've been giving him paracetamol at about 20 milligrams per kg. Well, at about 60 milligrams per kg per day, the fevers are not subsiding. So we want to take him to hospital so that tests are done and we know whether he has a viral infection or not. But if he has a viral infection, then he doesn't need to be prescribed for an antibiotic. But quite often, you go to hospital, you have some viral pharyngitis, and you're given an antibiotic, amoxicillin, co-amoxiclav, azithromycin, and that contributes to AMR. Sharing of antibiotics. I hope this doesn't happen in Zimbabwe, or is it Zambia, where somebody is given a 7-day course of antibiotics. They use it for 2-3 days. They're feeling better. They leave the 3-4 doses remaining, keep them somewhere. Next time somebody has similar symptoms, they use the same antibiotics, whatever remained last time. Yeah, so you end up having some therapeutic doses of antibiotics, antimicrobials in your bloodstream that leads to AMR. Growth promotion in agriculture, in animal health and agriculture. You may or may not be aware that antibiotics are used to promote growth in animal health and agriculture, and actually globally, it is estimated that 70% of the global antibiotic consumption is in the animal health and agricultural sector, not even in the human health sector. Lots of antibiotics are pumped, in farms, in animals. Here in Kenya, especially in the rural areas, it is not strange if your animals are unwell and you call this guy who claims to be a vet, and they come over and they do their diagnosis without the assistance of the laboratory. And quite often they even come, to your farm or to your village with an antibiotic already. So they'll do their quick assessment and administer an antibiotic to your, to your cow, to your pig. And these are the animals that we end up consuming. And that's why we will get to learn when we talk about the One Health approach, where it is important not only to have the human health folks involved in combating antimicrobial resistance, but also the environment folks and also the folks involved in animal health and agriculture. Poor infection control that ends up leading to disease-causing pathogens proliferating. So if we prevent infection, then we will not have infection and we'll reduce the need to have an antibiotic. And when you use antibiotics, even when they are used appropriately, over time, the microorganisms develop resistance. So you can imagine what happens when there is misuse, when there is overuse of antimicrobials. So it's important that we maintain good infection prevention and control practices, and it starts from simple hand washing community to good IPC practices in the typical healthcare setting. Poor quality of drugs also does contribute to AMR. When your meropenem or your amoxicillin or your azithromycin or your macrolides or your aminoglycosides are substandard, when your amoxicillin is not 500 milligrams as claimed on the label, then you end up having subtherapeutic doses of your antibiotic, antimicrobial, and as a result, AMR is propagated. Weak waste disposal systems does contribute. We do not know how the pharmaceutical industry disposes of waste, especially waste that is from the manufacture of antimicrobials. These again go into the environment. Microorganisms are exposed to these low levels of antibiotics, antimicrobials, and develop resistance. These bugs are consumed by animals. We end up consuming these animals. We end up, and the cycle continues. So the resistant bugs from the environment to the animals to human beings. So the day you are in the high dependency unit or you're in ICU and you really, really need that third line cephalosporin, right? You already have resistant bugs in your system. You will not benefit from that third line or fourth generation cephalosporin. Poor food hygiene, and again, this goes with poor infection control. It's important that food is cleaned well, food is cooked well to avoid spread of antimicrobial resistance. These are some of the various ways that AMR emerges and spreads. So the question is, why is it a global concern? Why is AMR a global concern? Why is it of concern to the global community? Why is the World Health Organization concerned about AMR? Why has it come up with strategies, interventions to prevent and contain antimicrobial resistance? Why is it an agenda item in the United Nations General Assembly every September in New York? Why is there why has the UN come up, the UN Assembly come up with strategies, come up with teams, to ensure that, systems are put in place to prevent antimicrobial resistance? So it is noted that new resistance mechanisms are emerging, and not only are they emerging, but they are spreading globally. Right? And it's worth noting at this point that the pharmaceutical industry is not so keen on developing new antimicrobials. Why? Because the return on investment is low. Like we said, even if antimicrobials are used appropriately, over time, superbugs still develop. Microorganisms still develop resistance to these antimicrobials. The typical antimicrobial antibiotic will be used for 5 days, 10 days, 14 days, if you're in critical care, 21 days, I guess, at the most, depending on what is being managed. So like I said, the return on investment is very low. So the pharma industry will not be keen, is not keen on investing, spending money when it comes to research and development to develop new antibiotics. The pharmaceutical industry is more concerned about developing medicines used for chronic conditions, the non-communicable diseases, hypertension, cardiovascular diseases, diabetes, cancers, because there is a return on investment. If somebody develops a non-communicable disease today, if you develop diabetes, for instance, you're likely to be on meds for the next 10, 15, 20 years. So from a business point of view, I'd rather spend money on research and development for medicines used for chronic conditions. I mean, if I develop a newer a newer glitazone, for instance, for diabetic patients, they're likely to be a need for 10, 15 years, as opposed to an antibiotic, 5-day course, 7-day course, and even with appropriate use, it's just a matter of time. It will no longer be effective because of resistance. So the pipeline for new antibiotics is as good as dead, really. And somebody can confirm if there's really been any new molecule, any new antibiotic in the last 10, 15 years. Most of them are just slight modifications of existing molecules. So AMR is spreading globally. New antibiotics, the antibiotics that are there are becoming ineffective by the day. Those that are effective are reducing by the day. And like that, we'll be discussing about stewardship shortly after my presentation. How do we use the few antibiotics that we have optimally, judiciously? I know Tapio will be discussing that. So AMR is an increasingly serious threat to global public health that requires action across all government sectors and society. And you may be aware that in 2015, WHO developed a global action plan on antimicrobial resistance, and countries were challenged to develop their specific, the country-specific action plans on antimicrobial resistance by the year 2017. I think by the time we go to 2017, not many countries had developed their specific action plans. I can't remember the numbers, but a few countries, and I'm glad to note that as Kenya, we beat the deadline. We completed our action plan just before the World Health Assembly in May 2017. In a nutshell, the Global Action Plan has 5 key strategic focus areas. Strategic focus area number 1 talks about creating awareness on AMR to the public, to everyone. And I'd challenge you, after this meeting, call your neighbor, call your friend. Tomorrow when you walk out, just ask somebody, do you know what AMR is? And probably spend some 30 seconds, spend a bit and just explain to them what AMR is and show them how they can contribute to preventing and containing AMR. So one focus area in the Global Action Plan for AMR is creating awareness on AMR. Number 2 is on surveillance. Basically, we need to track resistant trends. We need to track antimicrobial consumption rates. Remember, we say that overuse leads to, contributes to AMR. Number 3 in the Global Action Plan talks about infection prevention and control, and we've talked about that. Number 4 talks about appropriate use of antimicrobials, and that's what Tapio will be talking about. And number 5 talks about research and development and resource mobilization to combat AMR. The Global Action Plan has 5 strategic focus areas, and countries were charged to develop their country-specific action plans with reference to those 5 focus areas. So governments across the globe were charged to develop country-specific. I know Zimbabwe has one, I know Zambia has one, Kenya has one. Many African countries actually right now have their country-specific action plans on antimicrobial resistance. The third bullet there, without effective antibiotics, the success of major surgery and cancer chemotherapy will be compromised. So if we do not preserve, if we do not use the antibiotics well, the successes that have been achieved over the years in surgery, cancer chemotherapy would all be eroded overnight if the antibiotics that exist are not effective. And I think I've mentioned this, that we are far from developing antimicrobial agents generally. The pharma is not keen on developing new antimicrobial agents. So what are the effects of AMR? And I think we've mentioned some of these as we've gone along. Increased morbidity and mortality, that goes without saying. If I'm admitted today, or if somebody is admitted today in hospital with bacterial meningitis, and your 3rd generation cephalosporin, which is our first line here for bacterial meningitis in Kenya, is not working. And then, so what next? Probably you put on some broad spectrum antibiotic, maybe some carbapenem. So what happens? You end up staying in hospital for longer, right? If you're in hospital for 7 days, you end up taking 21 days. Increases costs, and unfortunately, you may even end up dying, and that's what we do not want. Economic burden, somebody always has to pay. Even if you have health insurance, you've paid your premiums, the government is contributing, or you're paying out of pocket. The time when you're in hospital, you're not working. If you're not working, then you're not able to support your family. You're not able to contribute to nation building. I mean, there's a gap where you work. So it has a strain on the economy of a country. When you fall sick, you're admitted, you put on antimicrobials, the antimicrobials cannot work because you have resistant bugs. So there are a host of factors. There are many other things that get affected as a result of AMR. And of course, increased cost of care. If in hospital for 2 weeks, 3 weeks, a month, cost of care increases. Yeah. There are quite a number of papers that have linked the impact of AMR to quite a number of the Sustainable Development Goals. Yeah, of course, for us, our main one is the one on health, SDG number 3, and it goes without saying. If you have multi-drug resistant TB, what does that mean? What impact does it have on you, the health system, and the community at large? We've talked about the economy. So quite a number of the SDGs will not be achieved just because of antimicrobial resistance. There's need for coordinated action, even as I come to the end of my presentation. So AMR is a complex problem that affects, all of society and is driven by many interconnected factors. Yeah. There's somebody who's telling us we were in a conference and somebody told us that in India, rainwater was tested and it was found to have traces of ciprofloxacin. You can imagine rainwater had ciprofloxacin. So that means that there's something somewhere wrong with the way ciprofloxacin or the pharma industry, the way some pharma dispose of their wastes. There's something amiss somewhere to the extent that rainwater has traces of ciprofloxacin. So this is just to show that, AMR is contributed by so many interconnected factors. So AMR does not recognize geographic or human-animal borders. Yeah, the same resistant bugs that are in the environment, that are in animals, end up getting to us as human beings. Single isolated interventions have limited impact. There's need for coordinated action to minimize the emergence and the spread of AMR. And all countries need national action plans on AMR, and we've talked about this. So this coordinated approach that is required is what is called One Health. Yeah, coordinated response to AMR. So you can see that diagram to your right or to my right. So we need the human health folks, we need the animal health folks, agriculture folks, we need the environment, and this is really a simplified view. We actually need so many actors involved to combat antimicrobial resistance. These are the three key players. So the One Health approach is a holistic and a multi-sectoral approach. At the global level, it involves the World Health Organization, the Food and Agriculture Organization, FAO, and the World Organization for Animal Health, OIE. I'm sure you must have heard of the tripartite. Yeah? And then recently, the UNEP also joined. In fact, I think there is a phrase now known as the tripartite plus. So it's the tripartite, these three global organizations, including UNEP, that is the United Nations for Environment. Now that we know that the environment also does contribute a lot in that cycle of spreading antimicrobial resistance. So what is One Health? What does One Health mean? So this WHO definition says that One Health is an approach to designing and implementing programs, policies, legislation, and research in which multiple sectors communicate and work together to achieve better public health outcomes. In other words, even in the development of national action plans to combat AMR, in activities to prevent and contain antimicrobial resistance, let us have human health, animal health, agriculture, and environment guys come together. If you have a campaign, a public rally, let's have all these guys come together and communicate how the various sectors are contributing to AMR, how the various sectors can prevent antimicrobial resistance. We cannot just focus on the human health alone and leave the agriculture guys. Remember, we say that actually the agriculture guys use more antibiotics than human beings. For those of you who are farmers or you have some background in veterinary medicine, I mean, we human beings will need probably some 500 milligrams of amoxicillin every 8 hours, right? The average cow will use way more than that, way more than the 500 milligrams, or way more than the 1.5 grams per day, right? So the contribution is key to AMR, and so they need to get involved in combating AMR. So what are the One Health goals? To ensure that microbial agents continue to be effective and useful to cure diseases in humans and even in animals as well. To promote prudent or appropriate use, prudent responsible use of antimicrobial agents. And here we'll be discussing that shortly. And of course, finally, is to ensure global access to medicines of good quality. Yeah. We want to preserve the medicines that are there, and not only to preserve them, but also to ensure that they are accessible, so that when I have that pneumonia, I have access to the antibiotic that will treat my pneumonia. Because again, quite often what happens in mainland middle-income countries, if my amoxicillin is not there, if my benzyl penicillin is not available with gentamicin to treat neonatal sepsis, then the doctors will prescribe whatever is available. Yeah, and in inappropriate use also, drives AMR. So we've talked about the One Health. So what are some of the One Health activities? So WHO, FAO, OIE are committed to raising awareness on AMR, strengthening national capacities to address the microbial resistance. So governments need to be strengthened. The capacity needs to be developed to be able to address AMR and to address AMR appropriately. These three organizations are committed to supporting countries to establish appropriate policy, institutional, and regulatory frameworks and networks to combat AMR. And they're committed to supporting harmonized AMR surveillance and global monitoring of usage of antimicrobials. Surveillance is simply just tracking. Currently in Kenya, we're in the course of developing a system to track our national antimicrobial use. The healthcare facilities or hospitals that have already started tracking, and it is as simple as last month we used X number of vials of subtraction, X number of vials of benzyl penicillin. And the previous month we used X plus the previous month. So we want to start asking ourselves, well, was there a fourfold increase in the consumption of benzyl penicillin, for instance, last month? Was there an increase in the disease burden that warranted the use of benzyl penicillin? So as you track consumption and start interrogating your data, you may find that there's actually inappropriate use somewhere and you want to correct that. And so even at country level, it's good to monitor usage even at country level, and where there's, where there's a feeling that there could be overuse, you want to interrogate and take action. And it's not just overuse, even underuse. If in a malaria endemic area, for instance, you expect the use of Coartem, if I use that brand name, although it's not good to use brand names, is very, very low. You have to ask yourself, then if these guys are prone to getting malaria, then why is it their use of these artificially combined therapies? Then what are they using? Yeah, so it is not always overuse, even where there's underuse, because then there's an appropriate use. Maybe there's something then that is being used inappropriately, and many times it is an antimicrobial that is being used inappropriately. Thank you very much for listening to me. I hope I have kept within the time. Ngoni, I can see it is 9 o'clock Kenyan time. Over to you, Ngoni. Thank you very much.
Oh, wow. Thank you very much, Mr. Jaguga, for such a wonderful presentation. Yeah, I learned a lot. I thought I knew about antimicrobial resistance, but I've seen that there were big loopholes. So, yeah, I've understood that when it comes to economics, some people may say, I'm an accountant, I'm not involved in this antimicrobial resistance thing. When I go to a pharmacy, I'm just getting my amoxicillin, and then I do what I do, and If I have maybe a pain, I can just go to the pharmacy and get my paracetamol, and then the pain is relieved. But then at the same time, when those patients or that accountant goes in continuously getting the paracetamol or maybe using the pain, sometimes it might not be about the pain he is having, but maybe it will be about maybe a viral infection. And then the pharmacist gives the accountant paracetamol where there's supposed to be an antiviral drug that's supposed to be working. And I've seen that as the time goes on, the antiviral drug will not even be able to work for the function that it's supposed to do. So this is one of the things that is increasing antimicrobial resistance, and then we will be needing a lot of money to revert the cause. And we need to, as an individuals, we need to come up with solutions, projects to work on this antimicrobial resistance thing. And also, when people talk of antimicrobial resistance, they leave the effect that even in agriculture, also antibiotics are being used. And as what just Mr. Jaguga has explained to us, they said, um, you know, when a cow needs to use an antibiotic, it can use 2 times the amount that a person might use. And then we can see that when the cause doesn't happen in these animals, we can see that antimicrobial resistance will come up in large amounts than we can expect. And then at the same time, after we have these animals getting this antimicrobial drugs and they have a good health and all, but then the resistance, you can get it from these animals when we eat it, when we kill it during ceremonies, in restaurants, and even at home. So either way, we need to embrace this thing of One Health, and then we explain it to farmers, we explain it to our fellows, our relatives, so that they understand what antimicrobial resistance is. So without wasting time, I would like to introduce our next speaker. So before I do that, I think I've said those questions, you can put it in the chat box. And I am sure my co-host, Mr. Ngara, is noticing that, so that at the end of the session, we will address those questions. So I would like to introduce our next speaker, Mr. Tapiwanashe Kujinga. So Mr. Tapiwanashe Kujinga is a lawyer by profession who started working in the legal practice before branching out into HIV treatment advocacy. He is currently the director of the Pan-African Treatment Access Movement at PATAM and is involved in a number of local, regional, and national roles. He is a member of the Zimbabwe National Antimicrobial Resistance Core Group. He chairs the National Technical Working Group on AMR Education and Awareness, and this organization acts as the secretariat for the core group. In these capacities, he is involved in the implementation of the Antimicrobial Resistance National Action Plan. So, Mr. Kujinga, you can take up the stand. Over to you, Mr. Kujinga.
Thank you so much, Ngoni. And good evening to all the audience. Ngoni, I've emailed you my presentation. Can you just can you upload it for me? Ngoni, you're speaking, but I think you're muted. Hello.
Let me do that, Mr. Kujinga. I haven't seen that.
All right. right.
Okay, let me share it.
Thank you. So whilst you are doing that, I just want to thank Dr. Jaguga for his presentation. The Zimbabwe National AMR Program benefited quite a lot from the organization that he was previously working for, which is called REACT. So we kind of like interacted quite a bit whilst he was still at REACT. So maybe by way of introduction, Zimbabwe started working on AMR in 2015. We already have what we call a core group, which is the governing body for AMR in Zimbabwe. We have 5 technical working groups. I think Colin has outlined the 5 broad objectives in the Global Action Plan, and those were translated into technical working groups, and I'm the chair of the Education and Awareness Technical Working Group. Also have an advisory committee made up of experts from fields within the One Health sector, human health, animal health, and environmental science, and they are helping to give us advice as when we need it. So the Zimbabwe National AMR Program is actually operational. Currently, we are implementing a number of laboratory tests through a grant from the Fleming Fund. So the program is capacitating central laboratories, the microbiology reference laboratory, and the central veterinary laboratory. And it will also capacitate some 12 provincial and institutional laboratories, which include a laboratory at the University of Zimbabwe, as well as the AMR laboratory. So we are doing quite a bit of work there. And in November, we will be having what we call the World Antibiotic Awareness Week, where a number of activities are going to be, to be implemented. And I just, we are having the planning meeting on Monday, and I hope some of you are going to be part of the activities, because we are planning to bring in students to talk about, what their professions can do on antimicrobial resistance. So I'm going to talk about antimicrobial stewardship as a strategy to combat antimicrobial resistance. Next slide, Ngoni. So, so what is antimicrobial stewardship? This is the responsible use of a critical and threatened health resource. In this case, you're talking about the antimicrobials that we depend on to prevent and treat infectious disease. So the presentation by Collins is, kind of like set out the scenario that we have, that some of the antimicrobials, if not all, no longer working because the pathogens that they are supposed to target are becoming resistant. So when they become resistant, it means you can take the antimicrobial, but it will not work. So if you're going to have like an operation, then it's going to be very dangerous, because you need to take antibiotics to stave off infection. And if that antibiotic does not work, then you are going to have a surgical site infection, which may result in death. So if there is no other alternative, it's going to be a very frightening era where we don't have antibiotics, just like what the situation was at the beginning of the 20th century. So the important thing is that we need to preserve the antimicrobials that we have through antimicrobial stewardship. Next slide. So why do we need stewardship? Why should we talk about stewardship? So I'll just give a background. So antimicrobial resistance is driven mostly, and I'm saying mostly, by the abuse, misuse, and overuse of antimicrobials. And these are mostly antibiotics. So what is the problem? The demand is driven mostly by patients. You know, what we've noticed is that when patients are sick and they go to the doctor, they expect a prescription, they expect to get medicines, they expect to get antimicrobials. So sometimes their condition does not need any medicine at all. But you know, they demand, and as a result, when they get those antimicrobials unnecessarily, that results sometimes in resistance. Because you know, if you take antimicrobials, especially when you don't need them, that can actually create a system or a situation where resistance builds. So I will talk a little bit about the data later, but next slide, Ngoni. So you will find there is a number of articles which talk about the significant increase in antibiotic use across the world. And over the last 10 years, there's been a significant rise in the use of antibiotics in a number of countries that are becoming increasingly wealthy. And these are mostly the BRICS countries: Brazil, Russia, India, China, and South Africa. Next slide. So this graphic presentation will also show you how antibiotic use is rapidly increasing in developing countries. So these are all countries, you know, where wealth is increasing. So you will see in Turkey, for example, antibiotic use has increased by nearly 50%. And you go down Spain, France, and so forth. These are developed countries. But when you look, for example, in Vietnam, right? That's a middle-income country. The antibiotic use has increased by more than 30%. In South Africa, antibiotic use has increased by 25%. Egypt by the same percentage, and so on and so forth. So this increase is actually driving antimicrobial resistance, especially antibiotic resistance. So as I've said, the data shows that the increase in antibiotic use is being driven mainly by countries which are experiencing economic growth. And it is estimated that 76% of the increase in demand for antibiotics is in the BRICS countries. So what happens is that when people are rich and they are not well, they will ask for antibiotics. There is a correlationship between wealth and the demand for antimicrobials. You will find that, especially, you know, in poor countries where people don't have money to buy medicines, they will just get by. You know, they will, you know, find other ways of coping. But when they've got money, they will go see the doctor and they will expect to be given antimicrobials. And this is exactly that, you know, what is happening in many of these countries where people are becoming richer. Next slide. And so this is also, you know, a map showing the percentage change in antibiotic consumption per capita between 2000 and 2010. Can you go to the next slide, Ngoni? Okay, so you will see, you know, in the countries which are shaded brown, you know, these are countries where antibiotic consumption is growing, and quite a number of countries are in Africa. We've got South Africa in the Southern Africa region. We have got some countries in West Africa, and you have a number of countries in North Africa, and in Europe and in South America. So this percentage change is actually translating into antimicrobial resistance. So you will find that in North America, for example, antibiotic use is actually declining, and that is particularly in Mexico, in the United States of America and in Canada and in most of Europe. They are actually in some countries in Australasia. These countries are actually actively discouraging people from antibiotic consumption. And in some countries, in particular in the Nordic regions, getting an antibiotic is very, very difficult. You will probably not get an antibiotic except if you have a certified prescription from a licensed and practicing physician. Otherwise, antibiotics are actually listed in the critically, in the critical sector. Otherwise, they are not just available, just like what happens here in Africa and in Zimbabwe. Next slide. So you find there's quite a number of articles which talk to the demand by patients for antibiotics. And when that happens, doctors will simply prescribe antibiotics, even though those patients do not need antibiotics. So you'll find that some patients will demand antibiotics when they've got flu. And that's a viral disease. It's not a bacterial disease, but they will want an antibiotic. And sometimes they get well because of the placebo effect. Sometimes when people take some medicine, they will then think, okay, this medicine is working, but yet it is your immune system that is taken over and it's actually combating the pathogen. So people actually feel sometimes that antibiotics are the drugs of choice. They are supposed to treat everything. So they will demand from the doctor, and the doctor will give them, and that in turn drives up antimicrobial resistance. And this is another article. How clinicians perceive demand for antibiotics in the outpatient setting. Next slide. Next slide, Ngoni. And this is another study, a mixed method study to understand patient expectation for antibiotics for an upper respiratory tract infection. So sometimes you then get inappropriate use of antibiotics simply because people just want them, even though they are not useful for the infection which they are suffering from. So I will talk more about the role of the pharmacist. What is the pharmacist supposed to do? Because I'm just putting this as a background. Next slide. So between 2016 and 2017, we actually carried out a survey as part of our program to write the Zimbabwe AMR situational analysis. So we wanted to understand, among other things, practices by pharmacists in dispensing antimicrobials. And this is the data that we got. So 87%, of the pharmacists say that they always dispense the antibiotics based on a doctor's prescription. What that means is that 18% did not. If you didn't have a doctor's prescription and you wanted an antibiotic, they'll just give you. And 54% reported antibiotics on the prescription of the pharmacist, which is not in line with regulation. So what this means is that a patient comes and then says, I'm suffering from laryngitis, for example, and the pharmacist will say, okay, for laryngitis, you would need amoxicillin. And so they'll sell amoxicillin to you, And 26% say their prescribing was influenced by a patient's insistence or circumstance. So the patient comes in, the patient wants an antimicrobial and insists that, can you please give that to me? I don't have money to go to a doctor. I am sick. If I go to a doctor, I will pay $20. For an antimicrobial, I pay $3. So why should I go to a doctor? And the pharmacist would then simply prescribe. And what they told us is sometimes the patients will say, if you don't sell that to me, I'm just going to get it next door. And you don't want to see money walking away. So they'll just say, fine, I will give you this antimicrobial you're asking for. And further, 42% confirmed having dispensed antibiotics for animal use, some without a prescription. Now, as pharmacists, quite a lot of medicines are shared between animals and humans. So this is quite an interesting situation where, somebody wants antibiotics for animal use, and they'll just get that from a pharmacist instead of getting that from, from a veterinary shop. The most commonly dispensed antibiotics without a prescription were amoxicillin, cloxacillin, and cotramoxazole. So these are your first-line broad-spectrum antibiotics. And according to some of the data, which I don't have time to share, there is quite a high resistance in respect of these compounds. So you can then see the immediate association between overuse and abuse, and then a resistance. And finally, 57% of pharmacists reported that they were willing to sell antibiotics without a prescription. If they found themselves in a situation where they were asked, to give an antibiotic over the counter without a prescription, they were willing to do that. So this is the situation really that we have in Zimbabwe. There's also quite an interesting study which was carried out by some, a Zimbabwean team in collaboration with the London School of Hygiene and Tropical Medicine. It's called the FEBA study, Febrile Illness Evaluation in a Broad Range of Endemicities. It was conducted to understand the social context of antibiotic prescribing and use in Zimbabwe. So some of the findings were that there was a significant number of antimicrobials, especially antibiotics, that are being smuggled and sold on the informal market. And I'm sure all of you have witnessed that. If you go, for example, to Mpedzanamo, you will find antimicrobials being sold. If you go to 5th Avenue Shopping Center, you will see antimicrobials being sold. I mean, one time some guy wanted to sell an antibiotic to me. I looked at it. There was no package insert. There was no manufacturer. There was nothing. It was just a packet, and which was labeled. And I thought, we are in real trouble. But one of the most disturbing findings was that some of the smuggled antibiotics are being purchased by registered and practicing pharmacists, and then just put in a plastic, and then they're sold to you. And they don't go through MCAS. They don't go through the Medicines Control Authority of Zimbabwe. So sometimes you don't know whether you are getting an antibiotic or you are getting some other compound, or whether if it's an antibiotic, it's got the right dosage of active pharmaceutical ingredient, or it's got a suboptimal dosage. And like Colin said, if there is suboptimal dosage, that also contributes to antibiotic resistance, because the dosage will not be sufficient to render the pathogen inactive. The pathogen will find a way to resist, to that compound, and that also creates antimicrobial resistance. So these are pictures that were taken from Mpedzanamo. So you see there's amoxicillin capsules, there's metronidazole, there's ciprofloxacin, there's endomethacin, there's a whole lot, and to your right, you will see that's a Shangan bag, which is used to carry the antibiotics. And these people, especially during the COVID outbreaks, were doing, roaring business, because people were taking antibiotics for COVID-19. Next slide. So let's talk about the fundamentals of antimicrobial stewardship. So the main objective of the stewardship is to improve antimicrobial use, slowing the rise of antimicrobial resistance whilst contributing to improved patient outcomes. So you may know as pharmacists in training that our antibiotic pipeline is actually almost dead. The last class of antibiotics was discovered in 1987. So we've got very few antibiotics. And like Colin said, one of the things that is contributing, one of the reasons is because pharmaceutical manufacturers are now concentrating on chronic diseases where people are buying medicines on an ongoing basis because that's where the money is. And antibiotics which you take for 7 days and you are healed, no, there's no, there's no interest. So antimicrobial stewardship then entails the dispensing of antimicrobials that are required by the patient in response to the particular pathogen or pathogens to be eliminated. You are targeting the disease that the patient has, and you are using the antimicrobials in a rational way so that you don't overuse and you don't underuse. Next slide. So stewardship implies not only appropriate clinical decision-making for individual patients, but a perspective that one maximizes overall benefits. What is the benefit of giving a patient, this particular antimicrobials? It also minimizes adverse events related to antibiotic therapy. You sometimes see prescriptions where a physician is listed 4 antibiotics, and those are for one patient. Or, a patient is on a particular antibiotic therapy, it's not working, the physician will add another one and add another one. Sometimes you see patients with 4 antibiotics that they are taking concurrently. And that is very dangerous because you are definitely going to get adverse events when that happens. But importantly, it delays the onset of widespread microbial resistance to commonly used antibiotics. So, when you slow down AMR, that is the main goal of antimicrobial stewardship. So the ultimate goal is to optimize patient outcomes while avoiding an increase in the number of antibiotic-resistant organisms encountered over time within each hospital, and thus maintain the effectiveness of the antibiotics currently available. And that is stewardship. Stewardship means you are given something and you are going to use it responsibly and rationally. You are not just going to waste it. So what is the role of pharmacists? So pharmacists are not a standalone profession. They work within the health value chain. In other words, you're working with doctors, nurses, laboratory scientists, and infection prevention control personnel. But in all this value chain, the pharmacist is the one who is holding the medicines, right? So you are the one who is entrusted with the antimicrobials. And so you are the gatekeeper against misuse, abuse, and overuse of antimicrobials. Next slide. And so when you're talking about antimicrobial stewardship programs, some countries or health systems have developed such programs. And these are integrated multidisciplinary structures which are created within health systems or within individual health centers to create systems for the rational prescription and dispensing of antimicrobials. So you just don't have one discipline represented. You've got a whole chain of disciplines which are looking at whether antimicrobials are being dispensed rationally, right? Within the whole chain. So it's not the doctor, for example, simply to decide that my prescription should stand. The doctor should be questioned, should be held accountable. And the nurse as well should be held accountable. The laboratory scientist, will generate, results. And on the basis of that result, the doctor or physician should be able to make a decision as to what antimicrobial should I dispense. And so it's a chain. It's not just one person, it's a multidisciplinary team that is created, or system. Okay, next slide. So in these programs, there is a retrospective surveillance of antibiotics consumption data, that should be performed with regular benchmarking. And this should be discussed with the prescribers, pharmacists, and infection specialists. So, these teams will then look at the antibiotic consumption patterns to find out whether they are in line with the threshold that would have been set. And where there is clear evidence that there is overuse or abuse, then the team should be able to discuss that and come up with a position. Standard reports should be designed to allow for regular and consistent comparisons of antibiotic utilization. I keep on talking about antibiotics because that's where the main focus is. And then the pharmacist should use available reference tools to research medicine information. And this is critical to build up a level of trust between doctors and pharmacists for this work. So the pharmacist should not be a bystander. The pharmacist should be able to critically analyze, for example, the prescription which has been issued by a doctor based on the, the guidelines. For example, in Zimbabwe, we've got the ADLIS, and the ADLIS is a tool which every health worker should know. And every health worker should know the medicines that are indicated for particular conditions or diseases, and the contraindications. So when there's a level of trust between doctors and pharmacists, they should be able to discuss, for example, what is the most optimal drug regimen to give to a particular patient. Next slide. So within the this antimicrobial stewardship program, the pharmacist has got a niche which he or she occupies. So the pharmacist should report the types of intervention suggestion for each patient on a monthly basis in order to determine the value of the pharmaceutical service offered and whether there is improvement over time with regards to antibiotic stewardship principles. So what this means is that the pharmacist is no longer a bystander. What normally happens is the doctor will write a prescription, send the patient to the pharmacy, and the pharmacist dispenses. But the pharmacist now is taking an active role to check whether the disease is in line with the prescription. So the pharmacist should be able, for example, to look at the number of patients on therapy who are being treated different to guidelines, and then inform the doctor accordingly. The number of patients receiving antibiotics with the duplicate spectrum. So you are actually getting patients who are being treated for something that they don't have. And the number of patients on therapy longer than 7 days. When an antibiotic course is longer than 7 days, then there's a problem. Number of patients where microbiology results were prompted. So sometimes the doctor can actually treat a patient syndromically whilst waiting for microbiology results. But when the microbiology results are received and they actually point in a different direction, then the therapy should be altered accordingly. The number of dosage alterations suggested, this speaks to the above, and advice sought for side effects. So where there's side effects, there is need to relook at the regimen. Next slide. There's also need for daily visits by pharmacists to the ward to review the antibiotic selection, dose, and duration of therapy. So pharmacists in conjunction with medical microbiologists or infectious disease physicians are well able to monitor adherence to antibiotic policies and stewardship goals. Now, this is different, from what happens. Pharmacists will just stay in their pharmacies and just give out medicine. But antibiotic stewardship or antimicrobial stewardship entails active surveillance, actively visiting the wards to check whether things are going according to the guidelines. It is also important that a report be compiled and updated daily to allow pharmacists and nursing staff to easily identify when antibiotics have been issued for longer than 7 days. So that, you know, where a patient is taking antibiotics for more than 7 days, that needs to go to the attention of the particular doctor or physician. Next slide. Again, a lot of antimicrobials are dispensed in the private sector through pharmacies which are run by licensed and registered pharmacists. And it is imperative that, you know, pharmacists dispense prescription medicines only on the production of a prescription. That is something that is very basic. But also questionable prescriptions should be referred to the prescribing doctor or physician, because, you know, sometimes we take it that the doctor should know, you know, the doctor should know what they are doing. I tell you something, sometimes they don't know. I've seen some very questionable prescriptions. I may not be a doctor, but I know, you know, sometimes where a prescription is, you know, not in line with what the patient should get. So in short, the role of the pharmacist should be a steward to the antimicrobials which are entrusted to the profession. You actually need to ensure that you only dispense accordingly and not, you know, irrationally. Next slide. So what are we doing is the AMR program. So we are actually in the process of planning to develop guidelines on antimicrobial stewardship. We should be having a meeting maybe within the next couple of months. So these guidelines will then lay the foundation on the development of a national antimicrobial stewardship program. And we are hoping that this program reaches all disciplines in the health profession and all health centers. And the implementation of the program will contribute to the reduction in the transmission of drug resistance in Zimbabwe. So next slide. Thank you so much for listening. I noticed that I've gone over time, but thank you so much for your patience, and over to you, Ngoni.
Thank you very much, Mr. Kujinga, for such a superb presentation. And I'm sure all the participants who are in here have learned a lot. And in terms of stewardship, I'm sure everyone needs to be part of it. And I've understood that there's a war between medical professionals or medical practitioners, where, for example, between doctors and pharmacists, because of money, where someone is not supposed to get an operation, they are being taken to an operation because a doctor wants money, where someone is not supposed to be given some medicines by pharmacists. These people, they're just being given the medicine because the pharmacists try to increase revenue. But then at the same time, it is increasing antimicrobial resistance. And such a thing has caused a lot of damage in how they're supposed to do their jobs. And one of the emphasis that Mr. Kujinga has embraced is that we need to join these AMR programs, AMS programs, so that we really understand how we're supposed to use these antimicrobials when we are being prescribed by the pharmacist, or when we are prescribing them ourselves, or even the doctors when they are writing the prescriptions, because everyone needs to learn pertaining this thing, because it's very serious and it's something that is of utmost importance. Thank you very much, Mr. Kujinga, for that presentation once again. And for the time and moment, I'm sure we've arrived to the question and answer session. And I don't seem to find Mr. Ngara. If Mr. Ngara, you're around, you can just announce the question so that the speakers can attend to it, and we continue with our session. So over to you, Mr. Ngara.
Okay, if he's not there, can I proceed and respond to a question that has been asked in the chat?
Okay. You can.
Yes, there's a question there that has been posed, and I believe it's addressed to me. So the question is, do superbugs only deactivate antimicrobials, or do they also have attack mechanisms? So I guess what this question is asking is really some of the known mechanisms of antimicrobial resistance. So there are generally, 4 major mechanisms by which microorganisms acquire resistance. So number 1 is a situation where there is decreased entry of the drug into the bacterial cell, or what we can say decreased uptake. So that's one mechanism by which microorganisms acquire resistance. Number 2, there could be alteration or interference with the antimicrobial's target molecule, or what we call, target modification. The third mechanism by which microorganisms develop resistance is inactivation of the antimicrobial, which I think is what our colleague was asked the question referred to as deactivation. And the fourth mechanism is a situation in which there is increased export or expulsion of the drug from the bacterial cell, or what is sometimes known as increased efflux. So those are the 4 common mechanisms by which microorganisms acquire resistance. That includes deactivation or inactivation, like our colleague Matsekwa has cited. Thank you, and over.
Okay, thank you very much, Mr. Jaguga. Dr. Jaguga, sorry. So I think you've been well answered. And I don't seem to see any other question here. So without wasting much time, I would like to invite Mr. Hope Mashawa Kure, our ZPSA contact person from the IPSL. So over to you, Mr. Hope. He is going to give us our closing remarks for this session. So, Mr. Hope, you're free to take the stand. Thank you.
Hello, everyone. Good evening. Can you all hear me?
Yes, sir. We can all hear you.
We can hear you.
Okay, thank you. I just dropped the question in the chat box. I'm sorry I did that late, but I wanted to ask to the presenters that are there any potential gaps that they've identified, more specifically concerning the research and development of antimicrobial agents, in which maybe undergraduate pharmacy students can look into, or so that they can do them on their research projects?
Maybe I can say something before my colleague Tapiwa does. This is an interesting question. So you're asking if there are any potential areas or gaps that, Tapiwa and I are aware of, specifically on the research and development of antimicrobials in which students can venture into other projects. The phrase there, I believe, the essence of that question is on development of antimicrobials. I'm not too sure this can be something within the scope of a student. I believe we're speaking to undergraduate pharmacy students mostly. I would believe R&D of antimicrobials would be at a slightly higher level, at the pharma industry level, at the microbiology point of view. So I'm not sure in your, say your final year project, you'd be able to get involved in R&D for new antimicrobials or even modification, probably changing, from your medicinal chemistry, removing a carbon here, hydrogen there. But I would imagine you could get involved in what Tapio has been talking about. Your project could focus on the appropriate prescribing of certain priority infections, whether you want to look into neonatal sepsis, whether you want to look at malaria, whether you want to look at meningitis, whether you want to look at community-acquired pneumonia. I believe that will be a more interesting project. That's just from a take, where you're asking yourself, what do the guidelines say? What should be our first line for community-acquired pneumonia? What should be our second line? What should be our third line? And are we adhering to these guidelines? You could focus on a particular hospital, for instance. So you could sample a number of patients who have had the diagnosis of community-acquired pneumonia or neonatal sepsis, for instance, and see. So our guidelines say A, B, C, D. But how are our patients being managed? Are they being managed according to the guidelines? And then you may find that probably 40% of the patients in that particular hospital are not being managed according to the guidelines. And so where are the gaps? What are the contributing factors? I believe that will be a more interesting project at your level. Not too sure about R&D in terms of developing new antimicrobials. Those are my thoughts. Over to you, Tapiwa, for any thoughts that you may have.
Thanks so much, Collins, and thanks for that question. I think it's really, I think it's a very thought-provoking question, especially for me, because being a lawyer, my area of expertise is intellectual property rights and innovation, and that's one of the issues I've been trying to drive within the AMR program. So looking at experience from other, other countries. So for example, if you're going to look at an HIV drug, which is called stavudine, right? Stavudine, I think it's D14. Stavudine was actually developed at Yale University, and it was discovered by the students. After being discovered by the students, because R&D is it's a very delicate process. It's very capital intensive, as well as skills intensive. So they then sold the patent to a pharmaceutical company, and that pharmaceutical company is the one that then holds the patent. Although stavudine has now been phased out as an HIV drug, but the pharmaceutical company made billions of dollars from that drug. And then I was actually reading about the new drug, the new antiviral for COVID-19. Maybe some of you have read about it. It's called Molnupiravir. I've actually put it in the chat box. So what I found interesting is that antimicrobial, that antiviral, was actually discovered at Emory University in the United States before being sold off. And I think right now the rights are owned by Merck. So in the States, because they've got a program which is called BADOIL, it funds a lot of research. They've got billions of dollars, and that money funds a lot of research across the board, not only for antimicrobials. So you find there's a lot of research that takes place within universities. But when research gets to a certain stage, especially when efficacy is actually confirmed in vitro, then the rights are sold to a research and development pharmaceutical company, which then takes it to the in vivo stage before going to phase 1 up to phase 4, of pharmaceutical development. Because sometimes it takes millions or billions of dollars, which, sometimes if you're at a university, you may not have access to. So what I think, sorry, if you feel, for example, that you've got the capacity, we've got a research and development technical working group, which is led by Dr. Wekwete, who is Deputy Director General of Medicines Control Authority of Zimbabwe. He has already linked up with Harare Institute of Technology. I think sometime we had what's his name? Is it Dr. Talon Garikai in one of our sessions, and we talked about this. So it's something that can be done at the very early stages. But when it comes then to do the final R&D, the rights have to be sold off to a cash-rich pharmaceutical company. But at least there will be some returns even at that level. So yeah, that's my response, and thanks once again. But yeah, if you feel you've got something, a good idea, you can also reach out to me, and then we can take it from there. Thank you. Over to you, Ngoni.
Yeah, thank you very much, panelists, for addressing Opmashaw Kure's question. And I believe this question was not just based to the panelists only, but to all of us. If you feel you have anything that you think you can help the one who asked the question with, you can reach out to him and give some ideas. And what he has asked, I think some of us can help similar questions, and I think the response have benefited us as well. So, Mr. Hope, you can continue with your remarks so that people can have a good night. Over to you, Mr. Hope.
Okay, thank you, Mr. Ngoni. Thank you, the panelists, for addressing my question. Let me jump into my closing remarks. So allow me to express my appreciation to the panelists for the valuable contribution to our webinar on antimicrobial resistance. I just believe that the webinar has performed a valuable function by unveiling the views from our experts. Okay, it has come to my light that antimicrobial resistance is a complex subject, and it is important that all of its dimensions are highlighted. I think that the webinar brought so many issues to our attention, and I congratulate the organizers for ensuring a high-level participation. Okay, finally, my deepest thanks are of course reserved for the education team, which is chaired by Mr. Ngoni Muzondo, for their priceless contribution and for running a smooth event as such. Thank you so much for giving me this floor. Have a blessed evening. I will be sending you all virtual chocolates, so be prepared. Thank you so much.
Thank you very much, Mr. Hope. You create some meals as you finish your remarks. And thank you all for attending this session. I think it has benefited us all. And please, let's this just not end here from what you've understood and grasped, but let us go out there and share the message, because most people are ignorant pertaining this antimicrobial resistance and antimicrobial stewardship thing. So it all starts with us. And as you all know, the saying "E publius unam," that is, from many minds we create one thing. So let's try to just come up with a lot of ideas, and then form those ideas. We correlate, we analyze, and then we come up with one thing so that we can fight this global pandemic, and we are able to live a happy life. So thank you all for attending, and have a good night. I'm now closing the session.
Thanks, Ngoni and everyone, and have a good night too.